You don't have to catch up with you. Yeah. In the back.
Well, hello. We're going to get started here. So first of all, let me just say welcome to the Advocate Summit. I'm impressed with the attendance and all of the different topics that's going to be happening here. Can you not hear? There is no microphone, so I'm going to try to speak loud. All right. And maybe we could close the doors so that the background noise isn't so much. Quick story here. About a week ago, my phone rings at like 7 o'clock at night, and it's Elizabeth Johnson who's calling me, and she's all upset because there were more people registered for this event here than in hers. So she's like, "You got like 5 more people than I do." So I have 2 children, an 21-year-old daughter and a 15-year-old son. When my daughter is extremely competitive. She has straight A's in college because she wants to get a A, right? Well, when she was 3 years old, we had to restrict her from playing Candyland because as soon as she started losing, she would actually take the Candyland Game Boy and toss it. She didn't want to lose. Then I have a 15-year-old son who I would play Mario Kart with on the Wii, and he would blow me out right every single time. But what he would do is when the game was almost finished, he would stop just before the finish line and then let me pass him. Oh. So anyway, what I wanted to say is I'm much more like my son. So Elizabeth is speaking at 2 o'clock in this room, so please come back so there can be more people for her. Right? Well, once again, thank you so much for being here. I really do appreciate it. I mean, we're talking about a topic that's I'm very, very passionate about. And if you don't, let me see if this is not working. Yeah, it's working. I pushed the wrong button. What I would like to do here is, first of all, how many people in this room have heard me speak before? Okay, so not that many. That's good. Because if you heard me speak, Tori, you might have heard this story that I'm about to share here. But it's a story that really grabs the attention of really defining what financial toxicity is and what financial navigation is. So let me just spend like 5 minutes telling the story, and then we're going to get into the meat of this presentation. So I was hired as an oncology social worker back in 2001. It didn't take long at all for me to start getting bothered by all of these financial questions that our patients were having. I was an oncology social worker. I have a master's degree in counseling. And I'm going to use this word here. I was bothered by these referrals. It was not my role to address this issue, right? That's something that financial counselors need to be dealing with. I need to be dealing with the mental health issues that our patients are struggling with, not their financial distress. Well, I would refer patients to the financial counseling office because patients were in financial distress, and patients would come back and patients were in financial distress. Help was not coming their way. And so I decided reluctantly to take a really deep dive into understanding what financial distress, we didn't call it financial toxicity back then, but financial distress and access to care. And I had an aha moment one day with this concept. Boy, if people just had better insurance, they would have less financial distress, right? Pretty simple, pretty basic idea. Problem is moving people from being underinsured to being more fully insured is extremely complicated in our healthcare system. Well, one day, a patient was admitted to the hospital. She was newly diagnosed with a cancer diagnosis, and she had just turned 65. So what does that mean? Medicare is coming her way, right? Or actually had already come her way. So I looked at her face sheet and I saw Medicare, and then I saw Medicaid as secondary, but with a spend down. You guys know what spend downs are? Right. When I interviewed her, I found out that her spend down was $800 a month. So she had to pay the first 800 every single month, right? It's not like a deductible that is once a year. It's every month that she has to pay this. And then after Medicare pays its portion, she pays 800, then Medicaid pays the rest. Well, back then, this was 2008, there was a Medicare plan that she could pick that cost $29, I think, or $25 a month. She would have 100% coverage for infusions, 100% coverage for radiation, 100% coverage for hospitalizations, and some very small copays to see the doctor for $25 a month. So I knocked on, she was admitted to the hospital. I knocked on the door, asked permission to go in and speak with her. She was sitting in her room. Lights were dimmed, and she was sitting at a table writing something on a piece of paper. So I told her why I was there, to talk to her about insurance and say, hey, there might be some other avenues here that we can get some better help. So she put down her pen and she goes, yeah, I want to talk. So I spent about 45 minutes with her, a long time. It was well worth it. 45 minutes explaining in detail how Medicare works, how it's put together. A, B, C, D, Medicare supplemental plans, open enrollment guidelines, all of the rules. So after about 45 minutes, she goes, well, this is sense. For $25 a month, I can basically get full coverage from my care. Yeah, I mean, I would like to sign up for this. So then I spent another 15, 20 minutes with her explaining to her, well, here's the process to do that. So we're all done, and I'm going to leave the room. And as I'm walking out of the room, she says, thank you. And I said, you're welcome. And I did a little small talk with her, and I'm leaving the room. And as I'm walking out of the room, she yells out, thank you. And I stopped again. I said, you're welcome. Did a little bit more small talk with her. I'm leaving for a third time. And she says, thank you. Now, time out here for a second. I have my master's degree in counseling. It was my intention as an oncology social worker to address the mental health issues of our patients, right? I'm going to be honest with you. I wasn't doing that. I had completely missed something. So after the third thank you, I walked over to her, I gave her a hug, did a little bit more small talk, and then she changed my life. Sometimes I get emotional about this story. I apologize. So she took out her finger and she put it in my face and she says, you don't get it. She was right. I had completely missed the distress that she was experiencing. And then she said, Dan, before you walked into this room, I was sitting at that table writing my funeral plans because I had chosen not to get care. I'm thanking you because I'm going to get care now. So I changed her life that day, but she changed my life, right? I walked out of this room, out of her room, a completely different person with a different attitude, with a different thought process of what our patients are going through when they are entering into this crazy world of medical care and oncology, right? And the expenses that they're being faced with. We wanted to call ourselves a center of excellence. And if we were going to be honest, if I was going to be honest, there is no way that we can call ourselves the center of excellence if we are allowing our patients to experience what she experienced. She had made the decision, I'm done, right? Because of the barrier of financial distress, of financial or patient access. So this aha moment here of going, well, we can band-aid this together. She would have qualified for our charity program, right? She had Medicaid spend down, easily would have qualified. We could have written everything off. But the problem with that is multifaceted. One of them is when you, especially in oncology, they're getting care from many other providers than just the hospital system, right? So sometimes the medical oncologist, they're a private practice, or radiation is private. All of the scans or the radiologist that's reading it might be billing separately. So even though we provide charity and as a band-aid here, the patient is still underinsured. Is that a fair statement? And then from the psychological standpoint of this, do you think most people want to be a charity case? I don't think so. There are patients that do, right? There are patients that demand charity, but most people, the psychological ramifications of that is of significance, right? So this concept here of, is it possible that we have somebody in the healthcare system? I am not going to be asking you, if you are running a financial advocacy program at your cancer center, that everybody in your system needs to be able to do what I'm going to be presenting with you here today. And I am asking, should we have somebody in the healthcare system that is knowledgeable about health insurance and can navigate people through that system? Our hospital CEO, our hospital vice president of nursing, director of oncology, the manager of oncology, the list goes on and on and on and on in our own health system, where those individuals have retired and they call me and going, Dan, can you please help me navigate Medicare? These are all professionals, right, who have expertise in the healthcare system, who don't have a clue about how to go through the Medicare process. And I'm just going to be challenging you as you're kind of listening to this talk of, shouldn't we have somebody in our system that is capable of doing this? So I'm not going to take the time to read all of this, but defining financial toxicity, it's twofold. It affects patients from a practical standpoint, lower income, access to food, rent, housing, transportation, but it also affects patients from a psychological standpoint as well. So real quick here, 27% of adult insured cancer patients reported medication non-adherence due to this. There's probably 400 different studies out there on treatment adherence and access to care and financial distress. It's very interesting. The statistics are very stable. Consistently, it's in the high 20s, low 30% of individuals are reporting non-adherence to care due to financial barriers. A 2018 survey found that 57% of cancer patients expressed anxiety regarding the financial burden of care. And in the same survey, 54% expressed anxiety from dying from the disease. Are you guys catching this?
Yeah.
Patients are more concerned about the financial distress that they're entering into than of actually dying from the disease. Prime example of that was the story that I just shared with you, that was her primary concern. How many of you have spoken to a patient saying, I'm not going to do this to my family? Right? Almost all of us. 7% of commercially insured metastatic prostate cancer patients paid more than $100 for Xiglu on their first fill. 31% of Medicare beneficiaries, so this is Medicare Part D, paid more than $2,800 on their first fill. Now, I know there's a lot of research out there on financial toxicity, and there's a lot of focus that financial toxicity affects the younger population, and there's reasons for that, right? They have less assets, many times lower income. But from a practical standpoint, as a financial navigator, I am spending the majority of my time wrestling through Medicare Advantage problems and Medicare Part D, right? And so now, with the Inflation Reduction Act that just got passed, there is help coming our way with Medicare Part D. Not so much with Medicare Advantage. And then this one is sad. 42% of newly diagnosed cancer patients have depleted their life savings within 2 years of their diagnosis. It shouldn't be like this, right? And there's a lot of blame. I'm going to talk a little bit at the end of the talk here about who's to blame for this. And I think we as healthcare providers have some responsibility in this as well. So here I'm going to get myself into trouble. So if you guys want to email me and complain about what I say, please feel free to do so. But what I want to do here is give you a 10,000-foot view of how I view different models that are addressing financial toxicity. Please don't use the word, when I'm defining different categories here. So I'm going to do financial counseling, financial advocacy, and financial navigation. Don't let those titles confuse you. It's more about what the roles are within these different models, okay? In healthcare settings, financial counseling, hospitals have financial counselors. Here I'm going to get myself in trouble again. I apologize. Generally speaking, they have a high school diploma and have very little knowledge about the disease state and the disease process. They have little access to medical oncology, radiation oncology, to be able to have dialogue about the clinical aspects of the patient's care. It tends to be isolated to, well, we can probably enroll this patient into Medicaid, or we can probably enroll this patient into our charity program. It tends to end there, okay? Now, if you have a financial counselor in your system that does a lot more, once again, it's more about what they're doing within the role, not the title here. So obviously, financial counseling has its problems here, right? There is so much more that can be done than just Medicaid and charity for people. And about 10, 12 years ago, oncology social workers or social workers in healthcare systems going, wait a minute here, this financial counseling model is lacking. We can do so much more. For example, we can do copay assistance programs, right? That pharmaceutical companies provide and that foundations provide. Fantastic. And we can get free drugs from pharmaceutical companies as well. Very, very helpful. And then there's lots of organizations out there, and we're honored to have Molly here in the room today, who is from the Pink Fund, who is a fantastic organization that says, hey, women who have been diagnosed with breast cancer, if there's a decrease of income coming into the home, we want to come in and make sure that you're stable. We'll help you with your mortgage, with car payments, and with lots of insurance and stuff like that, right?
BMC's on my board for KKC.
So financial advocacy has made a huge improvement to this model of financial counseling. But I want to point something out. What treatment modality does this address? Pharmaceutical, right? So these programs are fantastic when it comes to the pharmaceutical intervention that our patients will need. But in oncology, is it fair to say that oncology patients, all they receive is some type of pharmaceutical intervention? No, absolutely not. Actually, by the time they come to pharmaceutical intervention, they might have already met their out-of-pockets with their biopsies, with emergency room visits, with hospitalizations, with their surgeries, with the PET scans, maybe radiation. I mean, the list goes on and on and on. And so even though these programs are fantastic, and I am not complaining about these programs, it still isn't addressing the need and alleviating financial toxicity for a large patient population. And so financial navigation comes in and going, well, can we look at this differently? here? Can we, first of all, proactively treat this patient and really focus in on are there opportunities to educate this patient that, hey, you're underinsured, but you don't have to be. Here are some options for you, if that's Medicaid, possibly, but specifically in the Medicare world and the Affordable Care Act world, there are multiple opportunities to improve the coverage that they have. And then once that's occurred, now we're going to pull in these other two aspects here of financial counseling and financial advocacy. So let me try to show this to you here. But when we're thinking about defining financial navigation, first of all, I want to say this. We as healthcare providers, I'm going to be negative here for a minute. We as healthcare providers have done a horrible job when it comes to defining the role of financial advocacy and financial navigation. Every hospital system does it slightly different, right? And even within hospital systems, there are, this hospital does it this way, this hospital does it that way, right? And also, I think it's fair to say that most of the individuals functioning in the role have never been actually trained in how to do it. They're learning on the job. And let me ask you this question. If I was diagnosed with lung cancer, and I walked up to, since I work in a cancer center, I walked up to a medical oncologist and say, hey, doc, I've just been diagnosed with lung cancer. How should I be treated? What do you think that doctor's response to me would be? I need to know more, right? Just because I have lung cancer doesn't know, he or she wouldn't know, well, this is exactly what we're going to do. It all depends upon my stage, type of lung cancer, where is it spread to? All of those things are necessary to make a wise decision about what's the next step for treatment, right? Don't you think we should be doing that with financial navigation and addressing financial toxicity as well? The financial interventions, the financial navigation interventions are different based upon the clinical needs of that patient. I'm hoping to be able to show you some examples of this here in the upcoming slides here. So one more thing on this slide. English is not my first language. I was born and raised in Norway. Grammar, my wife reads my stuff and she goes, this is right? I don't know grammar. I don't know how to write. I get it. This is my simple attempt to try to define financial navigation. If there's somebody in the room who loves to be able to describe and put this together, I am all ears on how to define financial navigation. So this is just a draft, okay? But it's looking at incorporating the clinical knowledge. We need to get the financial navigator to be part of the treatment team. Thank you. I still think it needs more work. To be part of the clinical team, and then with that knowledge, start pulling in all of the different aspects of what we can do for patients to reduce their financial distress. So a broader perspective here, financial toxicity is a side effect of the disease that needs to be proactively treated, right? We should move away from this patient just called and they're in financial distress. Let's call in the social worker or the financial advocate. That should not be happening. I don't have it on my desk anymore, but I used to have on my desk. My goal is that a patient never calls in. Why? Because I've already addressed the issue before the harm was done, right? So we need to start thinking that financial toxicity is part of the clinical process that this patient is going through. It's not just, they're in financial distress. It is part of the disease process, and we need to treat it as such. The other thing here is I really want to emphasize here that financial toxicity is impacting a lot more disease states than just in oncology. Are there anybody in the room who's non-oncology here? Right. You're seeing it in a lot of other disease states as well. And so I know a lot of the research out there focuses on oncology. Right now, I can tell you I am more busy with MS patients than I am with oncology patients. So as you're thinking about putting together a financial litigation program, you really need to be thinking about beyond oncology. And then a new model needs to be proposed that can treat financial toxicity regardless of disease state and treatment modality. So, how many in the room here learn how to play an instrument? Good few. So, what is the basics of understanding how to play an instrument? How do you start? What's that?
Reading music.
Reading music, yeah. And you have to learn the scales. Don't make me sing, the song, do it in me. I can't do it. So, but you have to learn the scales. And you know what? A good teacher would force a student to practice the scale, maybe in the key of C, over and over and over again until there's muscle memory there to be able to do it. And then the teacher goes, okay, now we're going to do it in the scale of G and the scale of D, and on and on and on, until that student can master it. And then the teacher becomes really mean and says, okay, take out the left hand. Now you're going to do the same thing with your left hand, and you practice, 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 practice for months and years to practice those skills. But guess what? If you have mastered the scales, what can you now do? You can compose a symphony. If you can master the scales of financial navigation, which is on the board here, you can compose a symphony for your patient. And you're going to be amazed here. I'm going to show you some examples of this and what you can do if you truly understand these systems beyond like medical. Medicare, A covers hospitalization, B covers outpatient care, C is privatization of Medicare, and D is prescriptions. You got to go way beyond that and understand how those programs actually work. What are the open enrollment guidelines? What are the special open enrollment guidelines? To really master that to make a difference for patients. So let's look at this. Here's a marketplace patient. I have like 5 or 6 of these, so I'm gonna have to go through these pretty quickly. 45-year-old single female and 2 dependent children with a new diagnosis of stage 4 breast cancer. She is self-employed with a yearly gross income of $85,000 a year. She is enrolled in an ACA policy with a MOP of $17,100. It's April 2022. She has had a 60% decrease in income since the diagnosis. Now, first of all, would you guys mind work with me here for a second? If you want to, if you would close your eyes and imagine what it's like for this lady. What is her experience? She's single, 2 children, 2 dependent children, and over half of her income has gone away, and she's going to owe $17,100 for her care. What do you think her experience? You can open up your eyes now, but what do you think her experience is? And what I just did with you guys here of imagining the emotional distress that this patient has, do we do that with our patients? I'm going to imagine that in most settings, we are not paying attention to the psychological trauma that this patient is going through. That's my guess, right? So what can we do here? She needs surgery. She needs biologic therapies and radiation treatment. So she needs it all, right? Now, we could do, well, let's see. What are some solutions? Here's her plan, by the way. There's the $17,100 max out of pocket. She is paying $708 a month. With, and this is an ACA policy, it's an Affordable Care Act policy, right? So she's had a 60% decrease of income coming into the home. Can she pay this? Now what do you think it's like for her?
I think she'd be eligible for Medicaid.
So I ran the numbers, and she's not.
She's like slightly over.
She's old. So we cannot do Medicaid for her. I did that intentionally because I knew that would come. So what can we do here? Well, financial counseling would come in and say, well, let's just give her charity. Right? We can do that. Absolutely. Would she meet charity guidelines? Probably in most hospital systems. But once again, she has stage 4 breast cancer. Do you think she's going to get many more medical bills than just from the hospital? Yeah. And is charity going to be addressing her $700 plus monthly premium? It's not going to be addressing it, is it? So then financial advocacy says, well, hey, there's more that we can do here. We can get her copay assistance, or we can maybe even get free drug for her. Probably not. But we can do the manufacturer copay assistance, and we would certainly enroll her into Pink Fund, right? We would certainly go after that to see if that could help with some of her issues. But we still have a problem. She still has a problem, doesn't she? So financial navigation, the way I view it, right, should be taking into consideration all of the aspects here, including her health insurance premiums. Is there a risk that she's going to be losing her health insurance? Absolutely. Well, if we have a deep understanding, and I mean deep, really taking a deep dive into understanding health insurance and then the marketplace, there's actually opportunities here. The premiums and the out-of-pockets that patients have in the marketplace are based upon your predicted income, not necessarily your current income, but your predicted. Like on November 1st, people who are enrolled in the marketplace are going to be calling the marketplace and saying, hey, here's how much I think I'm going to be making in 2023, right? When she enrolled into the marketplace, she was, I think it was like 85,000 or something like that. She had told the marketplace 85,000. Is that true? It's not true for her, right? She had a 60% of a decrease of income starting in April or May. So what can be done here is this is her policy. And I've done this many times with patients. Their income changes, they're in a marketplace policy. I've done this on the day of consult. The patient is there, newly diagnosed with cancer. The more proactive we are about this, the better. We pick up the phone and call the marketplace and say, hey, the $85,000 of income is not correct. Here's the new income. I can't remember what signal. I ran the numbers, but I can't remember. It was more in like the $30,000 to $40,000 range is her new income. Guess what happens to her policy? I want you to watch a couple of things. I want you to watch this, and then her premiums. After that phone call, her new out-of-pocket went down to $2,450. But I'm going to say more importantly, because these out-of-pockets can get band-aided by copay assistance if she's doing infusions first. More importantly here, I think we've rescued, right, that this patient is not going to be losing her health insurance. But if we take the standard approach, which happens in most hospital systems, that the patient comes in, diagnosed, treatment plan is put in place, the patient is treated. 2 months later, the bill comes, and now the patient is overwhelmed. This wouldn't work, would it?
How do you verify the income when you call?
So you can tell the federal government, here's my new predicted income, and then they're going to ask, okay, I think it's 90 days. In the next 90 days, you need to send us proof that this is actually occurring. So insurance optimization here, right, in my opinion, it didn't really 100% solve the problem, but it fixed the problem quite significantly. We can still oops, we can still use the copay assistance card. Here she has commercial insurance for those infusions. Or if that doesn't work, I would be very happy to provide charity rather than my 17,500. Is there something wrong?
The volume.
Should I be over there?
If you can for
Yep.
right now.
Sorry.
Let's see.
All right, I'm going to move on to the next one here. Oops, no, it's not.
Okay.
Okay. So here's is that the next one? Sure. Oh yeah, okay. So Medicare A and B only. Do you guys have them in your health system? Right? They're difficult to deal with, aren't they? Unlimited 20% responsibility for your care. So here's a 48-year-old married female with a new diagnosis of multiple sclerosis. Monthly gross income is $1,680 a month, and they have $12,000 in assets. She has Medicare A and B only. She is not enrolled in D, and it's August of 2022. Total treatment cost was predicted to be right around $330,000. Patient will owe 20% of the Medicare allowable, so approximately the patient will owe $38,000 for her care. No problem, right? So what can we do here? What are some solutions? Well, financial counseling would say, well, hey, we can get free drug. Let's say she needs opioids treatments, right? Genentech would be more than happy to say, oh yeah, she's Medicare MB only. Here's free drug for you. Or we can also do charity for her. But what I'm going to say once again, that puts a Band-Aid on the sore. It doesn't cure the problem. The patient remains underinsured, right? What would financial advocacy do? Well, they would say we can do copay assistance and or free drug, but once again, the patient remains underinsured. Financial navigation tries to look at, can we fix this for the patient? What was the month? Was it August? Okay. Is it open enrollment for Medicare in August? No, it isn't. So, boy, what can we do here? Well, we can enroll. There's something in the Medicare system called the Medicare Savings Program, QMB, SlimB, QI, and QDWI, right? That addresses QMB is Medicaid, so you get Medicaid as secondary. That would solve the problem. She's over income for QMB, but she qualifies for SlimB, which pays the what? Part B premium, right? So she's now going to save $170 a month out of her Social Security check. Is she still underinsured? Yeah. Didn't fix that problem, did it? Now she can enroll into low income subsidy, right? That doesn't fix the problem of B, but it certainly would provide prescription coverage for her. By the way, you don't have to be enrolled in D to enroll into LIS, but once you're enrolled in LIS, you can enroll into D anytime during the year if you're brand new to LIS. So now she gets significant help on her prescription coverage, but it's August. Can she enroll into a Medicare Advantage plan at this point? The rule is that if you qualify for MSP, LIS, and then there's a third one if you qualify for Medicaid, you can enroll into a Medicare Advantage plan anytime between January 1 and the end of September for an effective date of the first or the following month. Now, I'm not a huge fan of Medicare Advantage plans, but I am going to say that it's a lot better than having Medicare A and B only, right? Because with Medicare Advantage plans, you have something called a MUP, a max out-of-pocket responsibility for her care. She now can enroll, I just randomly picked one. I'm not advocating for Humana, but here's a plan. How much does this plan cost per month? Zero. She can get it for free. Plus $170 more a month is coming into her Social Security check, right? And what's the important thing here with this plan?
Right here.
She will have a $3,450 max out of pocket. Is that better than $33,000?
Sure.
It's a little bit better than $33,000, right? Now, this is she can enroll into this, and then now If there is, this is multiple sclerosis, right? So she can roll into a copay assistance foundation to help with that 3450 if she wants to, or if that doesn't work, we can do charity, or she can pay it, right? Those are the three different solutions there. Here's another Medicare A and B only patient. Income is slightly different. Here's a 70-year-old individual with lung cancer. Monthly gross income is $3,500, and I have $120,000 in assets. Will this person qualify for MSP? Nope. Will this person qualify for LIS? Nope. So, and it's August. By the way, do you think this patient is going to experience financial toxicity, even though they have $120,000 in assets?
Yeah.
Absolutely. This person is going to experience financial toxicity. So are we stuck here? Is there something we can do to help improve this insurance? It's August, it's not open enrollment. Well, financial counseling, free drug, financial advocacy, copay assistance. You would run out of copay assistance very, very quickly with a Medicare A and B only patient, right? It doesn't solve the problem. Financial navigation going, can we do insurance optimization for this patient? Here's another plan, Aetna Medicare Advantage Premier. Can the patient enroll into this plan? Is there anybody that can see something on the screen that says, yeah, this patient, or no, this patient cannot enroll into this plan? What do you guys see? What does that mean? Absolutely. Where are you from? So this is a 5-star rated plan. And the federal government says that if a Medicare Advantage plan reaches 5-star status, you can enroll into this plan anytime during the year, and it will go into effect the first of the following month. Now, not every county has a 5-star rated plan. I would say probably a third, I'm guessing right now, a third of counties across the United States, or a third of the population, have access to a 5-star rated plan. But if you in your county, or the county that the patient lives in, has access to a 5-star rated plan, they can enroll into this any time during the year. Medicare Advantage. Here's a 65-year-old single female with a new diagnosis of stage 4 ovarian cancer. Monthly gross income is $3,100 a month, and she has $48,000 in assets, and she has a MOP of $7,550. So she wants a second opinion at Mayo Clinic. She has a Medicare Advantage HMO policy. Can she get a second opinion at Mayo? Probably not. Highly unusual that in an HMO policy that you'd be able to do something like that. So she's going to owe $7,550 for her care. Can she pay that? Maybe. I would still argue that financial toxicity is probably happening here as well. But once again, one of her stressors is she really wants that second opinion at Mayo. Can she do something? Is there opportunity here for her to change her policy and be able to do that? I'm going to argue the answer is obviously yes, right? So she is 65. Let's say she's 65 and 8 months old. Can she purchase a supplemental policy? The rule is to get a supplemental policy is that you need to do that within 6 months of being new to Medicare. If you're past 6 months, the insurance company is allowed to ask health questions, and that supplemental plan is not accessible, right? But there's another rule in the Medicare Advantage system, and maybe I need to, I'm going to skip this, is insurance optimization, financial navigation. She is within her first year of being in a Medicare Advantage plan. And the rule is, if you're within your first year of being in a Medicare Advantage plan, you are allowed to get out of that Advantage plan and revert over to a supplemental plan, even though you're past 6 months of being new to Medicare. And when you're in a Medicare supplemental plan, how does access to care work in regards to networks? There are no networks. works. You can go anywhere where, as long as they accept Medicare, they accept the supplemental plan. And if she picks, um, if she picks a Medicare supplemental plan, then she also needs to enroll into D, so she has prescription coverage. Will there be a need for copay assistance for her? If she picks, the supplemental plans go by the letter of the alphabet, Medigap A, B, C, D, F, G, K, L, M, and N. If she picks G, does anybody know how much she would owe for her medical care for the year in 2022? $233 total for her medical care for the year. That plan will probably cost about $100 a month for her in premiums. But I'm going to argue paying $100 a month so that you owe $233, or you can pay zero premiums for a Medicare Advantage plan and owe $7,550. I think the conversation would be pretty simple with that patient. Medicare Part D, a 68-year-old married female with a new diagnosis of breast cancer. Monthly gross income is $1,640 a month, and they have $14,000 in assets. She has a Medicare Advantage plan with a $4,500 max out of pocket. It's July. Treatment includes surgery and oral inhibitor costing $14,000 a month. So when we calculate it through the Medicare Part D system, it's going that oral aromatase inhibitor is going to cost her about $11,000 for the year. Financial toxicity is obviously occurring here. So here's her plan. There's the I grants. Total cost $14,000. The Medicare system, by the way, calculates this wrong. The way it works in Medicare Part D is that during initial coverage in the donut hole, you're paying 25% of the cost of the drug. And they're just saying, well, it's 25% of 14,000, which is 3,514. That's not right. It's 25% of 4,430. The initial coverage is 4,430. Donut hole is 7,050, so it's approximately 25% of 7,050. So this should be more like $1,000. This should be more like $1,700, and then paying 5% on the rest. So the first time a patient in Medicare Part D fills a $14,000 medication, the copay is going to be right around $2,800. Then they go into catastrophic coverage where they're paying 5%. So for the rest of the year, $702. Can this patient do that? We can get free drug from the manufacturer here if there was no copay assistance available through a foundation. So that's one solution here. I'm going to skip through this. But can we do insurance optimization in Medicare Part D? And the answer is yes. Low-income subsidy is available for people. So your income needs to be below 150% of the federal poverty level, and there are some asset qualifiers as well. And there's 4 different levels to low-income subsidy. By the way, because of the Inflation Reduction Act, level 4 is going to go away, and that's good news because level 4 is just going to go into level 3. So now there's no more 15% coinsurance in level 4. You just will have these flat copays here because they'll all be in level 3. That starts in 2024. One quick thing on this. Approximately 30% of all Medicare beneficiaries across the nation qualifies for low-income subsidy. Half of the people who qualify are not enrolled. Right? Why? If we're providing financial advocacy services, if we're trying to treat financial toxicity, health systems should be enrolling people or helping people enroll into this plan, into this program. But I go into healthcare systems and I'm teaching the financial navigator, and they go, well, the patient was on any prescription, so I didn't enroll them into low-income subsidy. Like, what? No, this is part of the treatment plan, right? There are probably prescriptions coming down the road. And this patient, by the way, is on other medications, right? If we just did free drug here, well, that would put a huge band-aid on the sore. But the patient remains a problem with all of their other medications. If you enroll this patient into low-income subsidy, watch what happens to the copays. for I mean $9.85 for hybrids, and then the generics $3.95. This cures the problem rather than just keep putting band-aids on the sore with copay assistance and patient assistance programs. A couple of training programs out there. So ACCC has a fantastic program in regards to the financial advocacy boot camp. It's a self-learning modules. Highly recommend that you go through it. Triage Cancer, are they here? Is Triage Cancer at this conference? They have a good program as well, and they provide seminars and a lot of good information there as well. And now I'm going to be a shameless self-promoter here. My own consulting program or the training program that I provide, it's much more intentional, focusing in on training, the one-on-one training with your financial advocate or financial navigator. It's 16 hours of one-on-one training, classroom style training, but then more importantly, followed by a minimum of 12 months of mentorship. This stuff is confusing. If it was easy, everybody would be doing this, right? But they're not. It's a very focusing on training one specific person or two or three people within your healthcare system. All right. Couple of considerations here, and then I'm going to have a couple of minutes for questions. First of all, recognize that financial toxicity is affecting your patient population. This is happening everywhere, and to pretend that it isn't going to solve anything. Financial toxicity, I pardon the pun here, but has metastasized to other disease states as well. And I think we need to be paying attention to what's happening within your healthcare system. Every infusion patient in your infusion clinic, in my opinion, should be told about copay assistance if copay assistance is available to them. I have gone into healthcare systems that they say, no, we don't enroll people into this, but if the patient approaches us, then we try to help them. That's unacceptable. Every Medicare beneficiary that's in your system should be assessed if they qualify for MSP or and LIS. Half of the people who should be enrolled are enrolled. So we need to start being more proactive of enrolling people into these programs. Consider adding financial navigation service to your financial advocacy program. Once again, I am not proposing that we're taking all of your financial advocates and they need to become masters of all this. But if you have probably two at least, in your healthcare system that can master the understanding health insurance and navigating these complicated scenarios through the system, I think it will be well worth your time. The return on investment, I don't have any slides on return on investment. The return on investment of this is very significant. And then financial navigator role, I would not recommend that you blend it with other roles. I know a lot of systems say, well, our financial advocate does prior authorizations and they also do some financial counseling and enroll people into copay assistance. I'm going to tell you, if they're doing prior authorizations, which system is going to win? Prior authorization, right? And then if there's time to do financial navigation, they do it. But in most systems, that is not going to work. Last thing I want to say here, invest in training. And I know that is, I'm biased, right? Obviously, I'm biased. But I want to spend 2 minutes on this and then take maybe a couple of questions. Financial distress and financial toxicity, there's blame everywhere for why this is occurring, right? We can blame pharma because of high prices. Now, pharma also helps with free drug and copay assistance, so that helps as well. But there's blame there. There's blame from a health policy standpoint, right? Now, the Inflation Reduction Act is fixing Medicare Part D finally. So that's a good thing, but still there's much more that can be done from a policy standpoint to address financial toxicity. Health insurance payers, they can be to blame, right? Making the prior authorization process so difficult and deny for no reason at all, and you have to go through all of those appeal processes and high deductibles and out of pocket, so there's blame there. But I also have to say that there is a lot of blame on us as providers. First of all, from we also charging crazy amounts for some care, right? Let's just be honest. I know that I can hear a pin drop right now, but that's true. And then should we take some ownership here of, do we really know what we're doing when it comes to navigating people or patients through very complicated health insurance systems? And in most systems, in most health systems, we don't have the right staff or the right trained staff to be able to help patients navigate this. And so I know I'm biased. I'm happy to have pushback on this, but in my opinion, financial navigators should be trained in how to do this work. It shouldn't be figure it out on the job. Some places are able to do that. Most places are not. All right, that was my lecture. I apologize. Can we have time for like one or two questions or not? Okay, go ahead.
More comment than a question. This has been great, so thank you so much. Fantastic information. I'm speaking tomorrow. I wish I was going right after you because you teed up what I'm going to talk about really well. So for plug my session tomorrow, feel free to stop. Obviously, this is just there's so much that's relevant between the
Perfect. So any other questions here? There is, by the way, at the end of the day, I think it's 3:34, if I remember correctly. There's going to be a Q&A. So all of the speakers will be up here to answer questions. And I'll be there and I'll have to answer. And I'm here all day tomorrow. Please come up to me and ask questions.
Sir? I